So we are here in Unit 10, our final unit for pharmacology this semester. And the topics for Unit 10 kind of span a few different subjects. In this first video, I'm going to talk a little bit about the immune system. We're going to review the immune response, both primary and secondary, and then introduce a brief introduction to serums and vaccines. So the human body is constantly under attack from all kinds of potential invaders, including viruses, bacteria, fungi, even single-celled organisms. And the immune system's job is essentially to keep that all under control. To defend us against these potential pathogens, you can say, or eradicate them as effectively as possible. So the immune system, without the immune system, these things would be incredibly detrimental, if not fatal. But because our immune system is so efficient and effective, most of the time these things aren't that big of a deal. And occasionally they are, but in most cases, the immune system's able to get the upper hand after a period of time. So part of the immune system that's really important in this whole process is the lymphatic system, which I'm sure you learned about in physiology and anatomy. But the components of the lymphatic system essentially provide the body with immunity, which essentially is the ability to resist injury and infections. So the lymphatic system is made up of a network of cells and vessels, as well as tissues like the spleen and the bone marrow, to essentially provide surveillance, immune surveillance. So it's constantly monitoring all of our fluid as it leaves the capillaries, and then running through these, leaving the capillaries and then being sort of sucked into these lymphatic vessels. And that fluid, as it gets pulled into the lymphatic vessels, is known as lymphatic fluid. It essentially enters into these kind of blind-ended lymphatic vessels and then kind of starts slowly traveling through the lymphatic system. And while in the lymphatic system, and especially inside those lymphatic tissues, the fluid is presented, if you will, to all kinds of cells that are really important in this process, like macrophages and lymphocytes. And they're specialized cells that are able to, the lymphocytes specifically, are specialized cells that are able to recognize anything that's foreign, right? So it has the ability to recognize self from non-self, and that's a key component of the immune system. It's supremely important that the immune system, these lymphocytes, are able to recognize self from non-self, or differentiate, I should say, self from non-self. And most of the times they do this brilliantly and are able then, if necessary, to mount an immune response against these foreign invaders. So I know you get into that in great detail in different courses, but we kind of have to just revisit it briefly in order to move into our conversation on serums and vaccines. So without spending a huge amount of time on this, I want to just quickly, briefly describe the body's response to a foreign invader and how that looks in terms of both the first time the body's ever been exposed to this invader, which would be the primary response, and all the subsequent exposures, and those would be classified as the secondary responses. So here's a picture that has all kinds of stuff on it. And when we think about the ability to recognize self from non-self, we're really looking at what we refer to as the the adaptive defenses. So we have an invader introduced, and that's then going to stimulate both the innate defenses, which are what we kind of call the non-specific defenses, which is where the phagocytes, the macrophages and those guys fit in, monocytes, macrophages, natural killer cells, right? They're not responding to something, they're not recognizing a foreign invader as non-self. They just know that it's not supposed to be there, right? And they're kind of they don't really care necessarily what it is. They haven't been, I guess what I'm trying to say is they haven't been activated to recognize that particular invader. And this is where the complement cascade and in some of our inflammatory mediators like histamine and those guys, cytokines and those guys fit in. But what we're interested in our conversation, specifically as we work towards understanding or talking about vaccination, is this part of the picture, which is the adaptive defenses. So with the adaptive defenses, we start this whole process of the recognition of things that are not supposed to be there, the differentiation between self and non-self. So this is called either adaptive immunity or specific immunity. You may have learned about it. And the specific immune response usually is broken down into what's called the cell-mediated immune response, which you see here, which is going to facilitate or recruit the T lymphocytes, and the antibody-mediated, or you might have learned it as humoral mediated or humoral immunity, which is going to utilize the B cell line. But in both cases, this is referred to as adaptive or specific immunity. And so it all starts off by the presentation of these antigens to cells that recognize them as foreign. So essentially what ends up happening is a macrophage gobbles up some of this antigen and then presents a bit of that antigen on these complexes, which are called the major histocompatibility complexes, or the MHC complexes. When the antigen is presented on these MHC complexes, we refer to now this cell that was probably once a macrophage as an antigen-presenting cell. So what that antigen-presenting cell's role is to facilitate these specific immune responses. And you see we have CD4 cells, which we refer to as our T helper cells or activated T cells. And what these activated T cells or these helper T cells are ultimately going to do is they're going to stimulate both the antibody-mediated response, which you see down here, and also the cell-mediated response, which you see over here. And I know we're not going to spend a bunch of time on this, but just to kind of refresh our memory with cell mediation or cell-mediated immunity, what ends up happening is these helper T cells essentially are going to once the antigen is presented, the helper T cell is going to facilitate this adaptive response by basically turning on our cytotoxic T cells and alerting them to that foreign invader, if you will. And those cytotoxic T cells will then go and initiate a direct response on that infected cell, and they'll oftentimes will pop a hole in it and cause the cell to lyse. And then we also have regulatory T cells, which seem to kind of turn off this event once it's gotten under control. Whoops. On the other side of this, we have the antibody-mediated immunity, also facilitated by these helper T cells. So the helper T cells are really important in kicking off this whole process of the adaptive response. So when the helper T cell has been alerted to this antigen, what that can do is that can cause our B lymphocytes to divide and create either plasma cells, which will in the moment directly produce antibodies, which are going to work against that invader, or they're going to also produce memory cells, which will remember that invader for the next time. So the first time the antigen is encountered, we call that the primary response because it's never been seen before. And so what has to happen is this whole process that we just talked about. You know, the antigen has to get gobbled up, presented, recognized. The T cells have to be activated, and the plasma cells have to be created to secrete those specific antibodies against that antigen. So that's the primary response, and it takes time. The secondary response would be the second or additional exposures to that antigen that's already been presented, that's already been seen. So it's a known at that point. And since we already have memory cells against those antigens, then the secondary response is going to be a whole lot more efficient. So I'm going to show you a picture of that in a minute. This is a plasma cell. There's another plasma cell. Okay, so the primary response. This is the first time you see it. So kind of look down here for a second. So here's our initial exposure to the antigen at time 0. And you see that it takes some time before the concentration, so this is concentration of antibody. It takes some time before the concentration of antibody even starts to increase. So that's the primary response. It's slower, takes generally a couple days, upwards of 5 days, maybe a few less, maybe a few more, to start producing antibodies. And the overall concentration of antibody is really going to be pretty low, right? And you can see it can take weeks for the level of antibodies to actually peak. But the secondary response, which you can see here, is going to be a whole lot more efficient. So let's look at a slide on that. So the secondary response, or any subsequent exposure to the same antigen, it can be the second time, the third time, the 10th time, the body recognizes it because it's already seen this. The immune system already knows about this thing, this antigen, this invader. So it's much faster. The antibody production, there's different types of antibodies, which we haven't talked about in this class, but you can see on the slide there, IgMs and IgGs. And they peak and fall at different times, as you can see. IgMs tend to peak first. IgGs tend to take a little bit longer, but stay elevated a little bit longer. But overall, for our purposes, if all we need to look at is kind of this green line, right, which is just the total antibody, both IgG and IgM produced. So you can see here, this in this cream-colored box, again, is our primary response. So you've got your lag period of about 5 days, and then you see your total antibody concentration escalating, right? IgM followed by IgG, and then it sort of starts to come down again. And this is like, we're at 15 days here. So this is, we're out now, another probably 10 more days before we have this whole thing wrapping up. But if you look at the secondary response, so the secondary response, you see the secondary response when we have our exposure, you see this antibody, first of all, the response time is much faster, and more importantly, the total concentration of antibody is quite a bit higher. So it's both faster and stronger with more antibody being produced. Okay, so you can see there, and really what drives this secondary response is the memory cells, right? They already know about that antigen. They're waiting around for it, right? They're all set, ready, sitting in your lymph nodes, monitoring, running around your blood, looking for these antigens. And as soon as that antigen is encountered, those memory cells, we don't have to go through the whole process of the antigen presenting cell, the helper T cell being activated and all that. The memory cells can immediately start dividing to produce more plasma cells that produce even more antibodies. So the reason why we're talking about this is because vaccinations take advantage of this secondary response. Essentially, in a nutshell, the administration of a vaccination is providing the primary response. It's allowing for the formation, or the development, I guess you could say, of our memory cell army, right? Waiting for that. If indeed you do come in contact with the actual antigen, then you have memory against it, and your response will be much more robust and a whole lot faster. I'm going to show you as we get going some of the immunization schedules, but you can also go to the CDC's website. They have a whole lot of information about immunizations. So I want to briefly just talk about a couple different types of immunity in the context of vaccinations. One is going to be natural or acquired immunity, and in the context of acquired immunity, active acquired and passive acquired immunity. Okay, so types of immunity. So we have natural, or what we refer to as inborn immunity. So with natural immunity, and the other type we have is acquired immunity. So essentially, natural immunity is is inborn, right? It is what you are given. The best example of natural immunity or inborn immunity in terms of the human is whatever immunity you're born with, essentially, or that you produce on your own, I guess you could say. With acquired immunity, now this is really what we're going for with the potential for immunization. So with acquired immunity, the key to acquired immunity is that we have to we're either looking at making our own antibodies, and that would be active acquired immunity, or giving preformed antibodies, which would be passive acquired immunity. So active acquired immunity, one way to make your own antibodies is to be exposed, right? This happens to us all the time. You get sick, you're exposed, you make antibodies, and your body deals with it. So that's one way to do it. But we can also inject some form of the antigen, and this is what vaccinations are going to, this is where vaccinations fit into this. We can inject some form of the antigen, of which there's lots of different options, and we'll kind of go through them in a minute. And when we do that, we then make antibodies against that antigen. So a vaccine is just that. We're delivering some form of the antigen, whether it's attenuated, dead, but something antigenic. And then the person who's given the vaccine then makes their own antibodies. The administration of a toxoid is kind of the same thing in this context. With a toxoid, what happens is, again, you're administering a substance, and you are going to, and the person that's getting that substance is going to essentially make antibodies against it. So toxoids are certain pathogens secrete toxins, which are essentially what are responsible for the symptoms of the infections. So toxoids are essentially bacterial toxins that have been modified chemically enough so they're not capable of causing disease, but they are capable of stimulating the production of antibodies to that toxin. So a good example of this would be the diphtheria and the tetanus toxoids that are given. All right, so I mentioned vaccines. So let's talk about passive immunity for a minute. So passive immunity essentially is going to occur, when preformed antibodies are transferred or donated from one person to another. So one example of this is the mother to fetus. Maternal antibodies can cross the placenta and provide protection for the fetus and the newborn. Also, when a mother is breastfeeding initially, she's also passing preformed antibodies to her baby. Another example of passive immunity is the administration of some kind of gamma globulin, which is going to essentially you're administering antibodies. And this is done after maybe potentially someone's been exposed to, let's say, hepatitis. You can give hepatitis gamma globulin. I'll show you some examples of this in a little bit. Antivenins for snake bites are given this way. Also, if somebody has a potential tetanus infection and they may or may not be up on their vaccine, then they may be given a gamma globulin. Similar to a rabid dog, or if you get bit by a dog, they'll give you a gamma globulin. So the big difference between these two is that with the active acquired immunity, where we are allowing for the patient that's being administered the vaccine, in this case, to develop their own antibodies. But with passive immunity, they're not doing the work themselves. They're not going to create their own antibodies or giving them antibodies. So they're going to still have to potentially, get exposed and create their own antibodies if they wanted to have memory, right? So essentially we're bypassing the memory step in this case. The utility around passive immunity, a passive acquired immunity, is when, there's a risk that there's not enough time for the person to develop immunity, right? Or it's a severe enough danger and or infection that it's just not feasible for us to wait around to see if they can develop immunity. That's kind of, I think, the best way to think about it. Here's kind of a little summary picture of the two types, active and acquired, active and passive. So here's our kind of the take home. So administration of the vaccine or exposure to the antigen that stimulates the body to produce antibodies and memory cells. That's the key. With passive, it's the administration of antibodies, preformed antibodies or immunoglobulins, which gives passive immunity, which has a fast onset but only lasts for a little bit of time. They're not gonna make memory cells from this. I think this is the key, right? You see here the plasma cells being exposed to either the antigen or the vaccine, and they're making memory, but we don't see that with passive immunity. We're just giving the immunoglobulins. So the response is fast, but it's short-lived. And then the concept of a booster, right? So a booster is you give a booster after the initial vaccine, and the idea is it's just kind of maintaining your memory cells so they stay ready and able to mount a response if the time comes. All right, so here are some different options for types of vaccines, and there's no need to memorize this, but I just kind of wanted to mention it. So essentially there's 4 types of vaccines. There's attenuated, which are live. Live vaccines contain the microorganisms that are capable of replicating and causing disease, but they are, so they're really effective at inducing immunity, but they're not often used for vaccines because of the risk. You're giving them, a live antigen. In some cases, that would be live vaccines, just live vaccines. I'm sorry, I was saying the wrong thing. With attenuated live, so with attenuated, it's still an organism, but it's less virulent, if you will. So generally they've been knocked down, the virulence has been knocked down because they've used some chemicals to make them less effective, or they've been exposed to a bunch of heat. So the attenuated vaccines can cause, I should say, a mild or a subclinical case of the disease, but they allow for lasting immunity, lots of memory. Another option is an inactivated or a killed vaccine. So those inactivated, again, the agent, basically they've killed the microorganisms by heat or chemicals, and they are safer because the organism is unable to replicate, mutate, and cause any disease. So the killed vaccines or inactivated vaccines are used, and they're maybe not as effective, but they are still effective. I should have said for the attenuated, an example of an attenuated vaccine is the MMR, the measles, mumps, rubella vaccine. An example of an inactivated or a killed vaccine is the hepatitis A vaccine, and the new HPV, human papillomavirus vaccine, is also a killed vaccine. I mentioned the toxoids previously. So the toxoid is essentially made to look like the bacterial toxins, but it's been again modified so it's incapable of causing disease. And then kind of the newer ones we have are the recombinant technology vaccines. And essentially what's happened with these is they include partial organisms or proteins that are made in the lab. So probably the best example of a recombinant technology vaccine is the vaccine for hepatitis B. And again, essentially what they've done is they've re-engineered yeast cells. Traditionally, they use recombinant DNA technology, and they take yeast cells and they re-engineer them to produce proteins that are really similar to those found on the coating of the virus, in this case, the hepatitis B virus. And they allow the immune system to respond, effectively and ideally confer immunity. So that's just some of the types of vaccines. So I just want to kind of run you through some of the different options. Again, this is kind of outside of our course. And I have a couple graphics to show you. There's a whole bunch of them. We could spend all day going over all the different vaccines, the ins and the outs of them, which we're not going to do here. But again, a vaccine is just a suspension of either an attenuated or a killed microorganism. You can see some of the examples of vaccines: flu, mumps, pertussis, polio, rabies, tuberculosis, and the measles vaccine. I think it's pretty self-explanatory, but also just good to remember that you don't want to give, in my opinion, you don't want to give any vaccines to anybody whose immune system is potentially down at the time of the vaccine. The MMR is one that's been shown to be less effective if you're giving it to a child who has a cold at the time. Their immune system's busy, it's doing other stuff, so they're not going to produce antibodies as effectively. But I think it's a good rule of thumb to just not vaccinate anybody if they have any kind of illness, cold or otherwise. We mentioned the toxoids already. Diphtheria is an example. Tetanus is an example. So there's some controversy around vaccination in certain groups. And the reason why we vaccinate is illustrated here by with the sort of the history of the rubella vaccination. So the rubella vaccine was invented, as you can see, in 1969. And at that time, in the year 1969, there were about 60,000 cases of rubella, which is German measles, which is a normal childhood viral illness, but it does have some potential long-term consequences, one of which is sterility in males. So there's a reason for us wanting to eradicate rubella. So the vaccine was invented in 1969, and you can see that by the year 2000, once vaccination against rubella was standard of practice in young children, you can see that there was only 176 cases of rubella reported in the United States. You can see some of the numbers there in Africa where vaccine rates are lower, although that seems to be improving now. You can see that when they started vaccinating, the deaths went down quite a bit, but they still weren't vaccinating like we vaccinate here, so there's not quite as significant of a decrease. So essentially we vaccinate, they call it herd immunity, right? We vaccinate to everybody to protect, as many as possible. There's a couple that are controversial. For the pertussis vaccine was one that was potentially linked to brain damage, although it hasn't really panned out, or at least hasn't been shown to be a causative agent. There is some data that looks like vaccines might correlate with some adverse effects, but no causation has been proved to this date, and you can kind of see some of that there. They have kind of improved the pertussis. So pertussis is given in combo with diphtheria, tetanus, and pertussis, and they have included it, and they have improved it, so it's not quite as painful, but I don't know that I'd necessarily say it's any safer. There is a vaccine reporting system put into place. Healthcare providers are required to report all vaccine-related adverse effects to a organization called the Vaccine Adverse Event Reporting System, which is essentially a post-marketing surveillance program conducted by the CDC and the FDA. It's voluntary. The voluntary reports are submitted. There also is a national vaccination injury compensation program. If you or one of your patients is injured, you can contact that number and or look at that website and get some support in that respect. All right, I just included some pictures here for us just to kind of see. So you can see this was in 1983. This was the recommended vaccine, or the doses for the different vaccines. And then you can see in 2016, we have a much more robust vaccine schedule. The 2017 doesn't look that much different. You can kind of see the ages, and a lot of these are repeats, right? You start at, like, for example, with Hep B, you start at birth and then you do another dose at 2 months. Whereas this is the diphtheria, tetanus, and pertussis. You start at 2 months, you do it again at 4 months, you do it again at 6 months, and you do it again at 18 months, and then again at 4 years. So you can see there's, it's a lot different than what it was in years ago. Not just kids are immunized, adults should be immunized as well for certain things depending on their risk. Healthcare workers are considered to be high risk. This was off of the CDC website. This is for adults starting at 19 years of age and then going up from there. And again, if you're interested in this, you can look, but you can see what they're recommending. Flu for everybody. Here's a tetanus, diphtheria, pertussis, probably a booster. We've got our shingles, varicella vaccine for herpes zoster. And then we've got our different pneumococcal, meningococcal pneumonias. HPV is kind of a new one. You see that they're only recommending till about 26 years. There used to be an oral polio vaccine, and now we have a injectable polio vaccine, I guess you could say. And the oral polio vaccine was interesting because it was attenuated live organisms, which is easy to give. But one thing that it did do was an interesting thing was the people who were given the oral polio vaccine could shed the virus and they could vaccinate others that way, which was sort of interesting. But that could be dangerous if the person is either the person themselves that's given the oral polio is suppressed, has a suppressed immune system, or if they're around other people that have suppressed immune systems, because it's rare but possible to get an active case of polio or to give an active case of polio via this type of vaccination. So now they do the inactivated injectable vaccine, which it acts more like a regular vaccine, not conferring immunity to others nor risk to the recipients, nor the immunocompromised people. So here's a couple examples of passive immunity. Again, I sort of talked about this already. This is where there's no time to form our own antibodies, and instead we give preformed antibodies, or in the case of the mother to the fetus or the mother to the nursing baby, she's passing preformed antibodies. So this is not an immunization. I think that's the thing to remember. This is not an immunization. This does not confer immunity, right? This is a temporary solution, giving antibodies to hopefully bind up the antigens that are potentially present. So I want to just for a second talk about Rhogam, because that might be something that we're familiar with. Some of us are familiar with. So essentially what Rhogam is all about is, as we know, red blood cells contain surface antigens, right? And that's what we use to designate our blood type. The ABO blood typing system is based on the presence or absence of antigens and B antigens on the surface of the red blood cell. But there's also a second protein on the surface of the red blood cell that we call the rhesus factor, or the Rh antigen. If the Rh antigen is present, the person is said to be Rh positive, and if it's missing, the person is said to be Rh negative. Most people living, at least in North America, are Rh positive. The reason why we worry about this is because there's a disorder called erythroblastosis fetalis, which is a hemolytic disease of the newborn, and it's due to a Rh incompatibility between the mom and the baby. So this only happens if the mom is Rh negative, like you see on the slide there. So this erythroblastosis fetalis doesn't occur generally with the first pregnancy because the two types of red blood cells excuse me, are separated by the placenta, and the blood generally is not physically exchanged between the mom and the baby. At birth, however, their blood mixes, and the mom's immune system can react by producing antibodies against the foreign Rh antigen if she's Rh negative. So the presence of the circulating then antigens that the mom's produced against the baby is a potential problem for Rh incompatibility if she has another pregnancy. If she has another pregnancy and the baby is Rh positive, because she's Rh negative, then she has antibodies against the Rh positive antigen, and they can cross the placenta and destroy the red blood cells in the baby. And this can lead to all kinds of issues, including really severe anemia or brain damage in the baby, and maybe even death. So, how we get around this is we administer Rhogam, which is essentially a immunoglobulin that can, I guess you could say, that can prevent the mom from forming Rh antibodies. So there's no risk of incompatibility in the subsequent pregnancies. So traditionally, Rhogam is recommended at 28 weeks gestation, or within 72 hours postpartum, or within 3 hours of a spontaneous or induced pregnancy termination. The one thing about about this that's kind of tricky with, I said earlier that it usually is only a problem in the second pregnancy, but occasionally a woman may have been pregnant before and potentially had a spontaneous miscarriage and maybe developed antibodies and not known it. And so I think that is probably why we argue for all Rh negative women to be given Rhogam first pregnancy or not. So that's a good example of the administration of gamma globulins. So here's a picture of some of the immune preparations. So these would be used for passive immunity. Again, you don't need to memorize this, but I thought I'd give you an example, or just give you some examples, and so you could kind of see what's out there for a possibility. So we just talked about Rhogam here. Tetanus immunoglobulin is a way to go. We got Hep B. There's cytomegalovirus immunoglobulin, rabies, of course. Oops, I went back too far. So that kind of wraps up our conversation on immunity and vaccines, just a very brief and general conversation about vaccines, serums, and toxins. So we'll come back later to talk about hormones.